Greetings, welcome to my channel and to this playlist of resolution of USMLE-like questions I wrote to resemble questions you would find on the USMLE or other likewise tests or even on med school. And today we're going to talk once more about blisters, though this time it's a different kind of blisters, but I promise I'm going to change the topic for the next video. So here we have question 4. A 26-year-old female patient comes to the consultation with a complaint of itchy blisters on her knees and elbows for the past 3 months. She has no known allergies. She used to have chronic diarrhea in her adolescence, which improved on its own after she started a restrictive diet in preparation for a sports competition. She then decided to keep the diet and has only recently abandoned it while traveling abroad last year. Physical examination shows small blisters on extensor surfaces, interspersed with erosions, likely from scratching. Which of the following will likely lead to the most definitive improvement for her skin lesions? A. Topical prednisone anti-remission. B. Oral prednisone anti-remission. C. Intravenous immunoglobulin. D. Antihistamine use as needed. E. Cease gluten consumption. F. Restrict sugar consumption. G. Restart the exact previous diet. H. Long-term dapsone use. Okay, so this question I believe will be somewhat quicker than usual, because it's somewhat straightforward. You don't have any graph or image interpretation. After you have a young female patient, 26-year-old, that comes with itchy blisters on extensor surfaces for 3 months. So, this is already pointing us towards some possibilities. Itchy blisters on extensor surfaces, okay. But what is key on this question and will always be present both in a question and in a true clinical situation on this specific case, she had chronic diarrhea in her adolescence. It could be something different, it could be she has bloating, could be other options, but what we take from it is that she had some kind of digestive, some kind of bowel problem, which resolved on its own after she started a restrictive diet in preparation for a sports competition. So this means for us that there was something in her normal diet that was not being good for her, some kind of allergy, some kind of intolerance that was solved once she adopted this new diet. Now, there is no point in keeping the suspense here, you probably already know what it is. So, this is celiac sprue or celiac disease, clearly, because what you are seeing here is a dermatological manifestation of celiac sprue, which is dermatitis herpetiformis, which are very itchy small blisters. The name herpetiformis, herpes-like in the shape of herpes, already tells us that these are very small blisters. And since they are very itchy, the patient is prone to scratching and turning that into erosions. So, itchy blisters on extensor surfaces on a patient that has or had, but actually it's because she changed the diet, celiac disease, is pretty surely dermatitis herpetiformis. And what happens is that you have antibodies against some specific antigens such as anti-transglutaminase in celiac sprue, and you have a lot of IgA that will damage your small bowel mucosa, but that may also deposit on your skin and cause the appearance of these blisters. So, dermatitis herpetiformis is nothing more than the deposition of the IgA immunoglobulins on your skin rather than on your bowel. They are the same autoantibodies. And so, what's asking now is, what's the treatment for dermatitis herpetiformis? And we have quite a lot of options here. There is a saying, at least in Portuguese, I'm not sure if it translates well to English, that almost everything can be treated with corticosteroids in dermatology, and that if the patient is on steroids, you should take the steroids, but if the patient is not using steroids, you should start steroids. I'm not sure if it would translate well, if there is an equivalent saying in English. But of course, this is just a joke. This is not an actual recommendation, either for patients or physicians. But you obviously have here the first two options, which are going to be topical steroids or oral steroids. And this is not actually the treatment here. The treatment for the dermatological manifestations of celiac disease are the same for celiac sprue itself. Cease gluten consumption. Alternative E. If you stop eating gluten, you are not going to form antibodies against gluten. If you don't form the antibodies are not going to deposit. If they don't deposit, you don't get either the mucosal involvement or the skin involvement. So the solution is pretty simple. If you have celiac sprue, stop completely eating gluten. This will resolve your bowel problems, your intestinal problems, and this is also going to resolve your skin problems. Of course, from the point of view of a question, this is not medical advice. I'm not saying that if you are a patient with celiac sprue, that ceasing gluten is 100% sure to resolve all your problems. That may or may not be the case. However, if you see this on a question, it is going to resolve all the patient's problems. Because here it doesn't say which of the following will definitely solve all the skin lesions. It says which of the following will likely lead to the most definitive improvement. Will likely. So ceasing gluten consumption will likely lead to the most definitive improvement, both in the bowel symptoms and skin lesions. Then C, we have intravenous immunoglobulin. This has pretty much no basis here. Maybe if you were thinking about some kind of immunobullous disease or something somewhat different, but here these very small and localized blisters in the presence of celiac sprue, in the presence of intestinal symptoms, speaks strongly for dermatitis herpetiformis. Then we have the G, antihistamine use as needed. Antihistamines are widely used for allergies. They could be used, for example, if we're thinking about urticaria or the presence of wills. But here what we have are not really raised plaques. We have small blisters, and once again, when associated with the digestive symptoms, this is pointing very strongly for celiac sprue. And the treatment for celiac sprue, the most definite one, is cease gluten consumption, which is our alternative E here, the correct alternative. Then F, restrict sugar consumption. Here, he, or rather myself, since I wrote the question, is just trying to confuse you. There's no dermatological manifestation like this that presents as itchy blisters that could be somehow linked to diabetes. We have dermatological manifestations in diabetes, for example, but not itchy blisters. Then, G, restart the exact previous diet. Well, that could perhaps work after she was in remission when she adopted this restrictive diet by herself. However, there's no real reason to do this if we know the exact component that's causing her problems. There's no reason to ask her to adopt a restrictive diet that may be depriving her of important components, of important nutrients, if you know that just restricting gluten would be enough. And H, long-term dapsone use. And now here, dapsone is indeed used to treat some skin lesions, particularly these blistering lesions, including dermatitis herpetiformis. So you can start her on dapsone. However, The question asks for the most definitive improvement. Which treatment is likely to lead to the most definitive improvement? And while Depson is likely to ameliorate, to improve her lesions, what's going to definitely improve it, what's going to long-term improve it and cause it to go into remission is ceasing gluten consumption. Depson will improve, ameliorate it, but as soon as you interrupt Depson, it's going to worsen once more. Besides, interrupting gluten consumption is even better than Depson in treatment. So there is no reason to make long-term Depson use. You could start the patient on Depson for a momentary improvement, but as soon as it has been some time with no gluten consumption, we would expect the skin lesions to heal by themselves and go into remission. Long-term use of Depson is unlikely to be necessary. And so, this is a simpler question about dermatitis herpetiformis, and the key note to take from this one is that when you see dermatological manifestations associated with digestive symptoms, suspect something linking both of them. So, in the case of celiac sprue, you suspect dermatitis herpetiformis. I hope this has been useful. Thank you for choosing to spend your time with me, and I hope to see you on the next video.